Greetings. My name is Brandi Richardson, and today I will be presenting my Doctor of Nursing Practice project titled Implementation of the Mood Disorder Questionnaire in Primary Care. This project focuses on addressing a significant gap in mental health screening in primary care and improving early identification of bipolar spectrum disorders. I would like to acknowledge my committee members, including my chair, the second reader, and my community mentor for their guidance, support, and expertise throughout this project. Primary care is often first, and sometimes really it's the only point of contact for patients experiencing mental health concerns. That's how I became a psychiatric mental health nurse practitioner. I transitioned from the primary care setting. Many patients do not see a psychiatrist, and oftentimes there may not be any local psychiatric providers available. So instead, patients present to primary care providers with symptoms like fatigue, sleep disturbances, somatic pain, irritability, or depression. Here's the problem. Bipolar disorder is frequently misdiagnosed as major depressive disorder or unipolar depression, especially when patients are presenting during those depressive episodes. This misdiagnosis is not just a diagnostic issue. It is a patient safety issue. When bipolar disorder is treated as major depressive disorder or unipolar depression alone, patients receive antidepressant monotherapy treatment, which can worsen their symptoms, trigger mania, or lead to rapid cycling moods. It also delays appropriate mood stabilizing treatment. Many patients go years experiencing symptoms of bipolar spectrum disorders before they receive an accurate diagnosis. This leads to increased healthcare utilization, functional impairment, and poor long-term outcomes. At my project site specifically, there was no standardized bipolar screening process. Providers relied solely on their clinical judgment. At baseline chart review, there was a 0% screening rate. Again, 0%. This clearly identified a major gap in practice and an opportunity to improve patient care and outcomes. This project aimed to close that gap by introducing a structured, evidence-based screening tool, the Mood Disorder Questionnaire, which I'm going to refer to during this presentation as the MDQ. The literature strongly supports the use of the Mood Disorder Questionnaire in primary care. I'm going to highlight a few key points. First, the Mood Disorder Questionnaire is a validated screening tool originally developed by Robert Hirschfeld. It has demonstrated strong reliability and high specificity, around 96% in primary care. What does this mean clinically? It means the MDQ is very effective at ruling out bipolar disorder, which is critical in primary care where the time is limited. Second, research shows that many patients presenting with depression actually have underlying bipolar spectrum disorders. Without screening, these patients are often misdiagnosed and treated incorrectly. Third, more recent literature emphasizes the importance of measurement-based care. We're transitioning to measurement-based care in healthcare. This means payers are strongly recommending or mandating structured tools instead of relying only on clinical intuition or evaluation. Because while, yes, our clinical judgment is extremely important, it is not always consistent or sufficient, especially when you're in a busy primary care practice. Studies show that tools like the MDQ are quick to administer, easy to integrate into workflow, and effective in improving diagnostic accuracy. So overall, the literature supports implementing standardized screening tools like the MDQ to improve early detection and improve treatment outcomes. During this quality improvement project, my slogan became standardized screening equals better outcomes. This project was guided by the Plan, Do, Study, Act cycle. This framework is widely used in healthcare to guide quality improvement initiatives. Plan. Identify the lack of bipolar screening was established. It was identified. Do. I implemented the MDQ and provided staff education and training. Study. I evaluated the screening rates and conducted chart reviews. Act. I refined the workflow and improved sustainability. This framework allowed for a structured and systematic approach to implementing change within the clinical setting. This project used a quantitative, quasi-experimental pre- and post-implementation design. It was conducted in a primary care clinic utilizing the Henry Sheen Practice Management EHR system. The intervention included 3 main components. 1, staff education on bipolar disorder and MDQ use and scoring. 2, workflow integration into patient intake. 3, ongoing monitoring and reinforcement. This project was implemented over an 8-week period, allowing time for planning, implementation, and evaluation. This design was chosen because it allowed for evaluation. It allowed evaluation of real-world clinical practice change without disrupting patient care. A total of 283 patient encounters were reviewed. 114 charts during pre-implementation, 169 charts during post-implementation. The inclusion criteria were adults aged 18 and older. The exclusion criteria were those individuals with known bipolar disorder, any cognitive impairment, or inability to complete the screening. This sample reflects routine patient encounters, and this also supports real-world applicability. Data analysis included both descriptive and inferential statistics. Descriptive statistics were used to summarize screening rates. An upper-tailed z-test for the difference between 2 proportions were used to determine whether the increase in screening rates was statistically significant. This test was appropriate because the data was categorical, and the goal was to compare 2 proportions over time. Statistical significance was set at alpha 0.05, and there was a 95% confidence interval that was calculated. Now let's look at the results. Before the implementation, 0% of patients were screened. After implementation, 39.1% patients were screened. So what does that mean? It means that before this project, no patients were being screened for bipolar spectrum disorder. And after implementation, nearly 4 out of every 10 patients were screened. That is a substantial change in clinical practice. Statistically, the results were highly significant. P-value was less than 0.001. The confidence interval also confirmed a meaningful improvement. But more importantly, this is not just a statistical result. There was a practice change. This is a practice change. This means providers now have more information, better insight, and a structured way to identify bipolar spectrum disorders in primary care. There weren't any positive MDQ findings during the project period, but that was likely due to the short time frame, patient population variability, and also exclusion of known patients with bipolar disorder. Again, the goal of this project was not diagnoses, it was screening implementation. And that goal was successfully achieved. There were several limitations to be considered during this quality improvement project. It was conducted in a single clinical site. There was a short implementation period, as I just stated, which limits long-term evaluation. There wasn't a control group or any randomization. There weren't any positive screening results. And there was possible variability in staff adherence to integration of the MDQ into workflow. These factors do limit generalizability, but they do not reduce the significance of improved screening rates demonstrated during this quality improvement project. Bipolar disorder screening is often absent in primary care. This project supports evidence-based mental health screening in primary care. The findings demonstrate implementing a structured screening tool significantly improves clinical practice. Staff education and workflow integration are essential, and they were essential. Screening for bipolar disorder is feasible in primary care. This project highlights the importance of early identification and standardized mental health assessment in the primary care setting. This project has strong implications for nursing and nurse practitioner practice. Improving early detection of bipolar disorder, reducing risk of misdiagnoses and inappropriate treatment. It supports safe prescribing practices, and it enhances patient outcomes and safety. For nurse practitioners, this reinforces our role of clinical decision-making, leadership and quality improvement, and integration of mental health into primary care. In conclusion, this project demonstrated that implementing the mood disorder questionnaire in primary care significantly improved bipolar disorder screening rates from 0 to 39.1%. Again, that is a meaningful and measurable improvement in clinical practice. This project also demonstrated that screening can be successfully integrated into workflow in the primary care setting. Staff education plays a critical role in adoption, and primary care providers are well positioned to improve mental health outcomes of the population. Moving forward, continued use of the MDQ can improve early diagnoses. Integration into the EHR can also improve the consistency. Expansion across clinics can improve population-level outcomes. Ultimately, this project supports a shift towards integrated, proactive mental health care in the primary care setting. On a personal level, this DNP project strengthened my ability to translate evidence into practice, lead workflow change and implementation, use data to drive decision making, and improve patient safety and quality of care. It also reinforced my role as a nurse practitioner, not just as a provider only, but as a leader, change agent, and advocate for evidence-based practice. Wow, no positive screenings were identified during this quality improvement project. The primary aim was to improve screening practices, which was achieved with statistically significant results. Future studies should evaluate the diagnostic outcomes over a longer period of time. The goal of this project was not diagnoses. It was screening implementation and demonstrating the feasibility of adopting a screening tool for bipolar spectrum disorders in the primary care setting. The references used in this project support the validity of the MDQ, evidence-based screening practices, and quality improvement methodologies. Thank you for your time.